move on to look at the differences between typical and atypical antipsychotic. As mentioned earlier, both typical and atypical antipsychotics block D2 receptors. But for atypicals, there is another receptor blockade. That is the serotonin, or more specifically, 5-HT2A receptor blockade. That is why atypicals are also known as serotonin dopamine antagonist. Going back to the previous antipsychotic molecule, which looks like this. Now we have the additional 5-HT2A receptor blockade involved for this antipsychotic. So what happens when there is additional serotonin blockade? Just like human beings, neurotransmitters do not exist in isolation, they influence each other. So serotonin has an influence on the dopamine systems as well. So when the serotonin blockade, it blocks downstream dopamine release in the striatum, leading to lower EPS. For its role in prolactin, unlike dopamine, serotonin promotes prolactin secretion, and when there's a blockade, serotonin can no longer stimulate prolactin release, and you have low hyperprolactinemia for atypical antipsychotics. But just to complicate things further, it is not just those 5 receptor blockade involved in atypical antipsychotics. It's lots of other receptor blockade. For dopamine receptors, there's about 4. Then you have the muscarinic, and then you have the serotonin, and then you have the alpha adrenergic receptors, and probably there are others that I cannot include in this slide as well. Don't worry, you do not have to memorize this, but this is just to illustrate why atypical antipsychotics can be used for other psychiatric symptoms and how they cause certain side effects. These receptor blockade gives the medication an antimanic effect. These receptor blockade gives the medication the antidepressant effects. These receptor blockade gives the medication sedative effects. And these receptor blockade gives the medication cardiometabolic effects. Now that we understand those concepts, let's go back to typical antipsychotics. In the typicals, we block these receptors which produce the antipsychotic effect, but also the following side effects. There are several types of typical antipsychotics available, which is very important for you to know, because when you get posted to district hospitals, Clinic Satan, or in Ulu Tumbaleng one day, you may be the only treating doctor around, and these are the medications that may be available to you, as they are cheap. Okay. But what does low potency mean? This low potency typical antipsychotics and high potency typical antipsychotics. So what does it mean? It means that the low potency ones, their ability to block the D2 receptor is lower, whereas the high potency one is their ability to block the D2 receptors is higher. Low potency typical antipsychotics generally have lower EPS. However, they have greater anticholinergic, antihistaminic, and alpha-1 antagonist properties, which means that they are more sedating. Higher potency, on the other hand, causes more EPS, but they have lower anticholinergic, antihistaminic, and alpha-1 antagonist properties. For atypical antipsychotics, These are the atypical antipsychotics that we use in this hospital. Except for clozapine, the affinity to block the 5-HT2A receptor in the other antipsychotics is higher than the D2 receptors. Well, this is another explanation why they tend to be more tolerated than the typical antipsychotics. Among the atypical antipsychotics, the side effect profile varies depending on their receptor blockade profile. For example, quetiapine is more sedating, risperidone is higher tendency to cause EPS, but less compared to the typical antipsychotic. Weight gain is a problem for atypical antipsychotics and has to be carefully monitored. You have to regularly take the fasting blood sugar, fasting cholesterol. Make sure you measure the waistline and measure the BMI as well. Both atypical and typical antipsychotics are available in several forms. There's the oral tablets, and there's the sublingual, which dissolves very fast, for example, olanzapine or Zyprexa. And there's depot antipsychotics, for example, Flunitol, Modicate. And for atypical antipsychotics, we have paliperidone. The long-acting, the depot antipsychotics are long-acting. They are given intramuscular every 2 to 4 weeks. And the advantage is it improves compliance in patients who have difficulty taking the oral medications. In the last section, we'd like to talk about how do we prescribe antipsychotics. So there are several factors that guides us in deciding which medications we should use. One is efficacy. For example, you have the high potency, low potency, so that helps you to determine which medications that you want to use. The side effects and tolerability, which also have an effect on compliance. The cost is very important as well, and the availability, because certain medications are not available in certain hospitals, and the comorbid illness that the patient has. So for example, if the patient has existing diabetes, it might not be advisable to prescribe the patient olanzapine. But we must also remember that these medication treatment must be accompanied with psychosocial treatment as well. So in summary, in schizophrenia, there is dopamine hyperactivity in the brain. Antipsychotic medications act by blocking D2 receptors. Atypical antipsychotics is associated with less EPS and hyperprolactinemia. Patients should be monitored regularly for metabolic syndrome, and prescribing antipsychotics should be individualized and accompanied by psychosocial treatment. These are the references that I've used.